Trophoblastic microcirculation occlusion as an adjunct to electric vacuum aspiration for the treatment of endogenous cesarean scar pregnancy. In this video, we describe a simple adjunct treatment option called trophoblastic microcirculation occlusion, which could change subsequent high-risk electric vacuum aspiration in patients with an endogenous cesarean scar pregnancy into a routine conventional surgical procedure. Cesarean scar pregnancy occurs when an embryo implants in the fibrous scar tissue of a prior cesarean hysterotomy. It was recently established that 1 in 531 women with a cesarean scar will have cesarean scar pregnancy, and that 4.2% of ectopic pregnancies are cesarean scar pregnancies. These can cause serious maternal morbidity, including uncontrolled hemorrhage and hysterectomy, thus resulting in the loss of fertility. Various options have been reported for the treatment of cesarean scar pregnancy. However, at this time, the optimal form of management remains uncertain. The prevention of hemorrhage is essential for the success of treatment. When cesarean scar pregnancy occurs, a close view of the cesarean scar area can reveal the trophoblastic microcirculation. The syncytial trophoblastic cells erode the helicin arteries in the inner myometrium. The cytotrophoblastic cells extend as villi tissue into the syncytial trophoblast. Note that maternal blood enters the intervillous space between the cytotrophoblast and the syncytial trophoblast. The syncytial trophoblast, cytotrophoblast, and the intervillous space constitute the trophoblastic microcirculation. When terminating a pregnancy in cesarean scar pregnancy patients, the cytotrophoblast and villi tissue become detached from the cesarean scar and causes damage to the intervillous space. The openings of the helicin arteries, however, cannot be sealed because scar tissue contracts poorly, thus resulting in hemorrhage from the sheared trophoblastic microcirculation. Here, we describe the development of a novel adjunct treatment called trophoblastic microcirculation occlusion, which directly seals the trophoblastic microcirculation via the local and multi-point injection of sclerosant around the helicin arteries in the myometrium of the uterus. Thus, a breakage in the trophoblastic microcirculation at the termination of pregnancy may not result in hemorrhage in cesarean scar pregnancy patients. Trophoblastic microcirculation occlusion treatment consists of 4 steps: identification, blocking, checking, and removal. The first 3 steps are carried out as key aspects of the adjunct treatment, trophoblastic microcirculation occlusion. The last step involves electric vacuum aspiration. Step 1. With the patient in the lithotomy position, a transvaginal grayscale ultrasound was performed to locate the cesarean scar pregnancy lesion. The gestational sac with the yolk sac was embedded in a hysterotomy scar with an empty uterine cavity and a closed and empty endocervical canal. Then, a color Doppler ultrasonogram revealed rich blood flow around the gestational sac. Finally, we converted to contrast-enhanced imaging mode at a mechanical index as low as 0.08, thus enabling the generation of the most pure microbubble images with effective tissue cancellation. The essence of contrast-enhanced ultrasound is to identify the microcirculation in cesarean scar pregnancy. We also injected a microbubble suspension through the patient's cubital vein. Upon injection, continuous dynamic images were collected, thus demonstrating perfusion of the contrast agent in the trophoblastic microcirculation. Step 2. We used a 21-gauge needle consisting of a needle and a stylet. With the stylet in place and under concurrent real-time ultrasound guidance, we inserted the needle through the vagina and into myometrium of the uterus close to the syncytial trophoblast. Then, we removed the stylet, attached a 10 ml syringe to the needle hub, and applied gentle suction. The syringe contained 100% pure sclerosant called loramacrogol. If there was no flow of blood, the loramacrogol was injected into the myometrium surrounding the syncytial trophoblast. After injection, we reinserted the stylet and slowly withdrew the needle. This process was repeated a total of 3 times until the near syncytial trophoblast region was filled with the sclerosant, thus achieving a cap-like hardening effect. A total of 8 mL of sclerosant was injected. Step 3. A repeat contrast-enhanced ultrasound was performed after the sclerosant injection to confirm the therapeutic effect. Regions filled with the sclerosant showed as dark regions on the ultrasonogram. Below such regions, the perfusion of the contrast agent was significantly reduced, thus indicating the successful occlusion of blood flow in the trophoblast. Step 4. Electric vacuum aspiration was carried out 24 hours after trophoblastic microcirculation occlusion treatment. In the first round of suction, the suction pressure was controlled at 0.04 megapascal. The deciduous tissue in the upper and middle uterine cavity was aspirated. This was followed by the aspiration of deciduous tissue from the lower back wall of the uterus. A second round of suction was performed by targeting the catheter to the gestational sac and the villi tissue attached to the scar of the previous cesarean hysterotomy. This was carried out with a lower pressure of 0.02 megapascal. A total of 7 patients received the trophoblastic microcirculation occlusion treatment. This treatment significantly reduced the risk of hemorrhage during electric vacuum aspiration. One patient achieved an intrauterine pregnancy just 7 months after surgery. We began ultrasonographic examination from the second trimester onward to monitor serial changes in the lower uterine segment. The patient successfully gave birth to a live baby at 39 weeks of gestation by a repeat cesarean section. Although no cesarean scar dehiscence was observed, further research is needed to clarify the association between devascularization of the lower uterine segment and cesarean scar dehiscence. Surgical abortion of endogenous cesarean scar pregnancy with a high risk of intraoperative hemorrhage can be performed with the minimal amount of blood loss in a single electric vacuum aspiration when assisted by trophoblastic microcirculation occlusion treatment. This video provides a novel strategy for the treatment of cesarean scar pregnancy. However, although technically feasible, trophoblastic microcirculation occlusion as an adjunct has not been prospectively evaluated. Further studies on a large sample should compare its effectiveness to standard of care, and this is necessary before widespread adoption. Thanks for watching.